Hi everyone, my name is Victoria Fan, and I'm a research fellow at the Center for Global Development. And I'm here today to present our report, More Health for the Money, Putting Incentives to Work for the Global Fund and its Partners. This is a report that came out of our working group on value for money in global health, led by Amanda Glassman, our Director of Global Health Policy at the Center, and my colleague Meet Over and I also contributed, and many others. And we regret that we're not able to be there in person for this very important capacity building training on value for money, but we hope that this report is of benefit to all of the participants today. And to start off, I want to encourage everyone and welcome you all to visit our website, morehealthforthemoney.org. We have a fun video of speed drawing, it's a cartoon, and we also have some graphics and animations and also other videos and interviews on the website, which will help you get acquainted with our report overall. And would love to play you the video, but for technical reasons it may not be possible. But encourage you all to take a look on the website and watch it directly yourself. So just very quickly, our definition of value for money is quite straightforward. It's about the production and utilization of the mix of health maximizing health services for the available donor, national, and private resources. Basically, we want to maximize health for the given resources that we have from wherever they come. And the domains of value for money, as you might have seen from our website, has 4 areas. So the four areas is our framework that we use. The first area we focus on is on allocation, and this particular set of recommendations is about how to allocate resources to maximize value for money. And the second area is on contracts. It's about how to structure agreements to create stronger incentives for value for money. And these are all occurring before the money is dispersed. And then the latter 2 areas occur after the money has started to flow. And so in cost and spending, we look at how to collect and use cost data for commodities, supply chains, and service deliveries to leverage value for money. And the final area is about how to verify performance to generate greater incentives and accountability for value for money. And this particular framework can be applied to any sort of funding agency, whether it's your national government or a donor agency. And we chose to focus on the Global Fund to fight AIDS, TB, and malaria for a variety of reasons. But just very quickly to give you a quick overview of the organization, it was founded in 2002. To create a world free from the burden of AIDS, tuberculosis, and malaria. And it chose to focus, there was this large focus on these 3 diseases during the G8 summit in Japan in 2000. And over the course of its 10-year history, more recently, the Global Fund has been there was a sort of corruption, quote-unquote, scandal that arose from the news, largely from the Global Fund's own audit reports. There have been some issues raised by the board about the fiduciary and financial management. And since 2011, the Global Fund has been undergoing a number of different reforms, including to get better value for money. But there are a number of reasons why we at the Center chose to focus on the Global Fund. One, it's one of the largest donors for HIV/AIDS and the largest international donor for tuberculosis and malaria. And given this period of reform, we thought it would be a useful contribution to help the Global Fund to think through ways to get better value for money. So, as I mentioned, the report overall has 4 different chapters, and given the time constraints today, I will be focusing specifically on the first chapter on planning allocations. So in this chapter on planning allocations, the overall question is about how to allocate resources to maximize value for money. And we assess this current situation, and in summary, we find that in the past, the Global Fund has not always been directed towards the most effective interventions, the most cost-effective interventions, the most effective and cost-effective mix of interventions, and the highest impact target groups for specific interventions. So we're talking about key populations. So in the first set of recommendations of this chapter, we really want to encourage the Global Fund or any financing agency to think through about choosing the most effective and cost-effective interventions on commodities. And so we know that given a whole variety of different interventions, whether it's first-line treatment under directly observed therapy, short course for tuberculosis, we can save 200 lives for $1,000. Or compared to, say, second-line treatment under WHO guidelines for patients with multi-drug resistant tuberculosis, it saves far fewer lives for the same amount of money. And similarly, when you see this again and again, instead of having lives saved, this is how much it costs per year of life. So we're switching the denominator and the numerator. And so we see here that malaria bed nets are a really good buy. They're the most cost effective. And then a variety of other types of interventions, aspirin, beta blockers, household spraying, tobacco, all the way through antiretroviral therapy. More expensive, but still probably a good buy overall compared to other investments in other sectors. And yet, even with a tremendous amount of information in global health about what we know is effective and cost effective, there are still areas for which we are yet to learn what is actually effective. And I think this is particularly true in the area of HIV prevention. And we're talking purely about efficacy, we're not talking about costs. And in a total of about 48 rigorous studies, this is a study done by Nancy Padian of UC Berkeley, and she found that 36 studies found that there was no effect of a variety of different interventions. The ones that were effective were male circumcision, treatment as prevention, and a few others. But basically we're talking about on the order of 75% of the trials, and studies have shown that we still have a lot more to learn in terms of what's effective for HIV prevention. And the second key area within this chapter is about focusing on key populations. So not only do we need to focus on the most effective and the most cost-effective interventions, but we also need to focus on the key populations. So here's a quote from Tim Hallett of Imperial College London. HIV exists in hotspots amid a sea of much lower levels of infection. Within the highest prevalence corner of South Africa, a study has found that up to a third of infections may occur within just 6% of the area. And within those hotspots, we see that the risk of infection is piled upon specific small groups. So this really emphasizes the importance of these key populations, and more importantly, that we should focus our resources on those key populations in order to control the epidemic. And in this particular study by Forsyth and Stover and Bollinger, we see a huge mismatch, at least in Latin American countries, between the disease burden and the resources spent. So we know, for example, that men who have sex with men, MSMs, are a key population for many AIDS epidemics. And so that is the gray line, the gray line. So it basically shows that most cases of HIV are concentrated within these key populations, these gray bars, as high as 60% in Costa Rica, for example. And yet when you look at how much of the prevention spending is spent on these key populations, we see that far less is spent. In some cases, it's practically zero. And of course, it's not to say that these need to track exactly, but it's also probably the case that if you're spending nothing, there's probably something mismatched, and you're probably, as a policymaker, not targeting your interventions to the key populations which would stem a particular epidemic. And of course, in sub-Saharan Africa, it really depends on the type of epidemic, whether the epidemic is generalized or concentrated. But even within generalized epidemic, as Tim Hallett just suggested, there are still key pockets and key hotspots to target and to focus on. And so, given these two sort of key recommendations about focusing on the most effective and cost-effective interventions and on focusing on the key populations, a natural question that follows is, so what are we spending on? What interventions are we spending on, and on who are we spending it on? And so what we did here at the center was we looked at 5 different grants at the global. I'm sorry, not just 5 grants, five of them of 5 main countries receiving Global Fund funds, to see exactly what the money was being spent on. And these are using the program grant agreements. And so you can see some kind of distribution of funds from care and treatment to prevention to health system strengthening, M&E, and so forth. And of course, since we're using general information, we don't actually have detailed breakdowns of exactly, how much is going to ART, PMTCT, and so forth. But the point of this slide is to show that the importance of these budgets, because the budgets really tell us, what are we spending it on. And in the case of the Global Fund, because oftentimes the budgets are so aggregated without very detailed or fine information, it could be the case that there is some sort of specific knowledge within certain individuals about where the money is being spent, but often it's not even written down or recorded, and so it's actually really, really hard for an independent observer like myself to figure out what exactly is being spent on. And the similar story is true when you look at the key populations as well. So using the same 5 countries, you can see that oftentimes the budgets, the general budgets, the summary budgets, very rarely, in the case of India and the Philippines, actually say to whom the money is going to. And you would think, particularly in the case of India and the Philippines, where these epidemics are very concentrated in specific populations, whether it's sex workers or men who have sex with men or injecting drug users, that those are the populations to whom the money should be going to. And yet, oftentimes, perhaps for political reasons or other sort of sensitivity reasons, it's not listed in the budgets. But we would argue that having that transparency is so critical to know, where and to whom the money is being spent on. And of course, there's tremendous variation. Ethiopia is much better about being much more explicit about who is benefiting from those funds, and South Africa is a little bit better than say India or the Philippines. But this aggregate problem of not knowing where the funding is going doesn't only affect the Global Fund and the country or the principal recipient to whom the contract is set. It also affects other actors in the field. And so we see this in the case of the Institute for Medicine PEPFAR evaluation that came out earlier this year. One country representative interviewed for this evaluation said, countries want to know more than what's been planned in the PEPFAR country operational plans. They want to know where geographically the money is going and what services are being supported so that they can identify unmet needs. So the bottom line is that if a particular donor is not particularly transparent about where that funding is going to other donors or to the country itself, it creates substantial obstacles for ensuring that we're spending the money in the most optimal way. And finally, the fourth set of recommendations about optimizing investments for greatest health impact. And here we're making a recommendation about the importance of using modeling and sort of more finer techniques beyond sort of very crude techniques as the first two recommendations suggested. So yes, you must use the most effective and cost-effective interventions, and you must focus on the key population. That's sort of a very basic first step. But once you get beyond that, we would encourage countries to look more into sort of optimizing investments, for each additional dollar. So here, this is a study done by Till Berninghouse and other folks at Harvard University, and you see that the optimal intervention mix subnationally within a particular province of South Africa, the Western Cape. You can see here under a particular budget constraint of $100 million in a particular year, how much on what what would be the most optimal and best value for money for this province in terms of interventions. And so you see, initially circumcision should be a huge priority, as well as ART, and then over time circumcision should be less and less important, presumably after coverage is reached. And treatment as prevention also kicks in as well. But when you look at a different province, it really, because the epidemiologies are different, the key populations are different. For a different budget, say $400 million for this particular province, while circumcision is very important, ART, basically this particular budget constraint would suggest that under no circumstances does it make sense to be rolling out treatment as prevention until you first do circumcision and ART. And these kinds of modeling studies, some have said, are far too onerous, countries don't have capacity, but we actually don't think it's that much more onerous. You need to know what you're spending on, what interventions you anticipate to invest in, your expected budget over time. Is it going to be flat, increasing, decreasing? And you need to know the epidemiological profile, the prevalence by gender, by the key populations. So those are the 4 recommendations of our chapter, and we welcome you all to look further in the report itself, which is available on morehealthforthemoney.org. And if you have any questions, please email us, and wish you all a very successful conference.